The key to understanding the antiarrhythmics is to remember back to the physiology section when we understood myocyte depolarization and repolarization. We used this diagram to talk about it. Now, all of the class 1 antiarrhythmics block the voltage-gated fast sodium channels that are responsible for the upstroke of phase 0 of cardiomyocytes. Now, your book says that all of this is state-dependent. Now, what does that mean? Well, the sodium channel blockers are in different classes because each class binds to the channel when it is in a certain state, and also the different classes have a different affinity and take a different amount of time to dissociate from the sodium channel. Let's quickly draw those out. Remember, the sodium channels constantly fluctuate between three states. There is a deactivated or a closed state. There's also an open and inactivated state. This all has to do with the inactivation and activation gate. We discussed how the fast sodium channel has a voltage-sensitive activation gate. When the channel is open, here is our transmembrane channel, sodium can fly in because the inactivation gate right here and the activation gate on this side are wide open. There is a ton of sodium going into the cell. Sodium flows in when the activation gate is open. The transmembrane pore will then be blocked when the inactivation gate swings over to stop the influx. So let's draw that out. So here's our sodium channel. Again, sodium's flowing in. All of a sudden, boom, our inactivation gate will slam it shut despite that our activation gate is still open. And the last state is deactivated when the inactivation gate is going to return to its original position, but the activation gate on the outside is now closed, blocking any sodium influx. Now, class 1A drugs bind the channel when it is in the open or active state, which is why they are most useful at very fast heart rates, when this channel is open more often, when they need to get access to the inside of the channel. When is the channel going to be open more? It's going to be open more often when there are very frequent depolarization. Now, class 1B drugs bind the sodium channels during not only the open, but also the deactivated or closed state. Class 1C drugs are very potent blockers of the channel when it is in the open state, and they take the longest amount of time to dissociate from the sodium channel, which is why they decrease the slope of phase 0 the most out of any of the classes. Alright, now we're going to get a little bit more in depth with each class, starting with the class 1A. These bad boys, quinidine, procainamide, and disopyramide, block fast sodium channels in the active or open state. This means that they directly compete with sodium at the transmembrane pore when the cells are depolarizing at very fast heart rates. Here's a diagram that's going to help us understand. By blocking the sodium influx, we decrease the slope of phase 0. This means we're decreasing the velocity or speed at which sodium can influx through those channels. This will increase the time required to complete the action potential. So we increase the action potential duration because we have to get a certain amount of sodium to flow across the limited amount of available sodium channels for depolarization to be complete. Remember, these sodium channels are in high concentration in normal ventricular and atriomyocytes. Now, this effect on atriomyocytes is particularly useful in treating supraventricular tachycardias. Supraventricular tachycardia just refers to a fast heart rate that originates anywhere above the ventricles. Most commonly, this is in the atriomyocytes. Now, the ability of these drugs to bind sodium channels also helps to decrease the conductance of ventricular myocytes. This makes them great at treating very fast depolarizations of ventricular myocytes. We call this a ventricular tachycardia. Why do we have a prolonged QT interval in this situation? Well, you have to remember that these drugs also block the potassium channels that are responsible for phase 3, which is this repolarization phase here. Note how this will shift out phase 3 on the diagram. This prolongation of phase 3 is going to increase our QT interval. This also increases the action potential duration at the same time. So there's two different ways that's happening. Now let's repeat to make sure we have this in our minds correctly. How do these 1A drugs work? They block the fast sodium channels responsible for the phase 0 depolarization, and they also block the potassium channels that mediate our repolarization in phase 3. Even more important than knowing this are the side effects. Side effects are high yield because they can kill patients, or a patient will stop taking the drug because of the side effects. Let's start with quinidine. Quinidine, you need to watch out for its ability to disrupt the sodium channels of the hair cells within the cochlea, or within the sodium channels of the central nervous system. When it disrupts sodium channels of the central nervous system, it can lead to headache, and when it disrupts the sodium channels of the hair cells, it can lead to tinnitus. Some people call this tinnitus. This combination of symptoms was called synconism. This was first described this way because they saw these side effects from the people that ate the cinchona tree, therefore they called it synconism. People used to use sap for medicinal purposes, and they would sometimes overdose and experience symptoms including headache, tinnitus, hearing loss, and visual problems. This is a high-yield side effect. You must watch out for this. Now what about procainamide? Procainamide is famous for causing a lupus-like syndrome or systemic lupus erythematosus. Disopyramide is the bad guy here. It has an incredibly potent effect on suppressing the fast sodium channels to the point they can actually lead to such low contractility that you can actually give the patient systolic dysfunction, or if it's very severe, you can even toss them all the way into acute heart failure. Now, all of these drugs can lead to torsade de pointes. Why is this the situation here? What's the deal? That's not very cool. Well, remember, anytime we start messing around with the potassium channels that are responsible for phase 3 repolarization, we're going to predispose for QT interval prolongation, and this automatically increases our risk for torsades. Now, one last side effect that's kind of unique, and no one really knows what the deal is here, is that it can lead to a thrombocytopenia. So look out for someone with a low platelet count in the setting of starting a new Class 1A drug. Alright, great guys, now let's continue pushing on. Move on to Class 1B. Only 2 drugs here, lidocaine and mexiletine. Phenytoin can sometimes be included in this category, but it's a sodium channel blocker that's more commonly used to block sodium channels in the brain. Phenytoin's main use is to prevent seizures. Let's focus in on this diagram. Now, Class 1B drugs inhibit the same fast sodium channels that we discussed in the group previously, 1A. But unlike the Class 1A, these drugs will actually shorten the action potential duration. How is this possible to shorten the action potential if we're actually blocking the sodium channel? Well, it turns out that after phase 0, there are still some sodium channels up here in phase 1 and 2 that are opening. There are just very, very small amounts of them. Lidocaine and mexiletine will block these channels and obliterate this current that kind of fades off all the way into phase 1 and 2. This will eventually shorten the action potential because we stop the influx of sodium sooner than normal. Now, why does Class 1B preferentially affect post-myocardial infarction or ischemic myocytes or already depolarized Purkinje or ventricular tissue? Well, in ischemic tissue, the transmembrane potential tends to be around -60. This is much closer to neutral than the -85 we expect for normal healthy tissue. Depolarized tissue around -60 is at a more positive transmembrane voltage. This will require a longer time for lidocaine or mexiletine to dissociate. Why don't we use it for ischemic atriomyocytes too? Well, these drugs bind the best when cells have a long action potential because they want time to bind these channels in the inactivated state. Atriomyocytes depolarize very quickly, and this gives Class 1B drugs very little time to bind them. Now, you can use this for digitalis, aka digoxin-induced arrhythmias. The arrhythmias that are triggered from digoxin use are due to way too much sodium inside the cells. Remember, digoxin prevents the sodium ATPase from pumping potassium back in and sodium out of the cell. So it makes sense to use a sodium channel blocker, right? You're right, it's a great idea. All right, now let's move on to the side effects. Anytime you're going to be depressing the sodium conductance, you need to be careful of excessively doing that. Excessive block can lead to cardiovascular depression. Same concept goes for the CNS symptoms. There are tons of sodium channels in the brain. Lidocaine and mexiletine are very lipophilic. They can easily cross that blood-brain barrier and enter the CNS to cause problems. Lidocaine is the classic culprit for triggering seizures. Alright guys, we're now done with B. Let's push on to C. The Class C antiarrhythmics, flecainide and propafenone, are rarely seen clinically because of the high risk profile. This makes them high yield for a written exam though. Dangerous side effects are always high yield. Now check out this slope. It looks like something you could even walk up compared to the slopes that we saw for the 1A and the 1B drugs. What is this telling us about the ability of 1C agents, flecainide and propafenone, to block the fast sodium channels? is telling us that these are super potent. They take forever to dissociate from the sodium channels. These drugs are also capable of prolonging the effective refractory period of the AV node or potentially also an accessory bypass tract. Unlike Class 1B drugs, you never give Class 1Cs to a patient who just had an MI. This is a very bad idea. The cells in their ventricles just suffered severe membrane alterations and ions that leak across the membranes that were just changed. They're just waiting for an opportunity to start beating on their own if you block the override signal from the AV node. This is the main toxicity of the drug. In the setting of ischemic or structural heart disease, you can give these people new arrhythmias. Alright, now let's move on to the Class 2 beta blockers that you'll see every day of your life.